Welcome to Global Dispatches, a podcast about foreign policy and world affairs. I'm your host, Mark Leon Goldberg, editor of UN Dispatch. In this show, we discuss topical foreign policy issues. I have conversations with foreign policy thought leaders and luminaries who discuss their life and career, often with digressions about historic foreign policy events in which their life and career intersected. And we cover often overlooked issues in global affairs. If you want to learn more, visit globaldispatchespodcast.com. And now on with the show. My guest today, Amy Israel, is the Global Health Thought Leadership and Policy Director for the health and pharmaceutical company Lilly. In that role, she's recently launched a new pilot project to combat high rates of diabetes in 3 neighborhoods of the city of Indianapolis, Indiana. But this is a global health story. That's because the pilot project is using a model for health intervention that was pioneered in the developing world. This model is often called the community health worker model, and global health nerds will be familiar with its basic outlines. But in short, it is the idea of training people of the community to be the first points of contact between their neighbors and the healthcare system. This model is used throughout the developing world. I've seen it in action on some reporting trips to Ethiopia and Bangladesh. And in our conversation, Amy discusses how and why this model will be applied to 3 of the poor neighborhoods of Indianapolis, where rates of diabetes are exceptionally higher than in wealthier parts of the city and state. And we do discuss the link between diabetes and poverty, and also, more broadly, how health ideas created in the developing world are being applied here in the United States. This episode is something of a different take of a familiar story. I think you'll enjoy it. As always, please feel free to reach out to me using the contact button on globaldispatchespodcast.com. Love hearing from you guys. You can also hit me up on Twitter at Mark L. Goldberg. And do let me know if you have suggestions of people I should interview, topics I should cover. I know that I say that a lot, but I do mean it. All right, now here is my conversation with Amy Israel of Lilly.
So Lilly has a long history of trying to tackle health systems challenges in many countries all over the world. We started in tuberculosis a number of years ago, and around 2003, and then transitioned to tackling diseases where we know a bit more about these days, which are diabetes and related hypertension. That work started in 2011 in Mexico, South Africa, India, and Brazil. We learned a lot from the efforts that we did there. Lilly has a physical strong presence in the U.S., as well as in many other countries, but our corporate headquarters are in Indianapolis. And there was a strong desire to take the lessons learned from our other country programs and try and apply some of them to tackle challenges in our corporate center backyard. So because of the deep burden of disease and pretty large systemic challenges, and we thought we're ready to try and take a go at it.
And so what does this new pilot in the backyard of Lilly's headquarters look like in Indianapolis?
So we're partnering with a few different organizations. We have the Indiana University, it's IUPUI. We have IUPUI School of Public Health as one of our the lead partner. We have Eskenazi Health, which is the health system for people who don't have access to insurance or other services. We have Marion County, which is the local government, and then LISC, which is normally a housing partner, but they do a lot in community development. So together, all of these organizations are concentrating in 3 main neighborhoods of Indianapolis that have the highest prevalence of diabetes and the largest disparities to develop a community-based diabetes management program that uses community health workers along the cascade of care while also addressing some of the key social determinants of health.
So the community health worker model, it's interesting. This is something that I've seen being applied in places that I visited when I'm looking at health programs in like rural Bangladesh or Ethiopia. But now it seems that this model is being applied to like urban, Indianapolis, which is kind of interesting to me, which is why I wanted to reach out to you. So, like, are there similarities between the kind of, community health worker model that like global health nerds like me sort of are familiar with, and the ones that you're deploying in these neighborhoods in Indianapolis?
Absolutely, there are similarities. And I would say it extends beyond global health nerds like you to community organizers. So if you look at some of the key models of community organizing in the 60s or in the 30s, even in the U.S., they were heavily based on trying to address the needs of the specific issue, but going around the issue and tackling all of the spokes. So if we were to take that and try and tackle diabetes, we know that you need to keep your HbA1c level low. You need to keep your blood sugar low. You need to exercise. Everyone knows they need to change their diet. But knowing those and actually being able to action them are two different things. In the global health space, we've learned that community health workers can be that arm to reach out into the neighborhood and support people along their path of care. We know that community health workers in places like you mentioned, like Bangladesh or in Ethiopia, are addressing many more things outside of just the someone's blood sugar level. Mm-hmm. But what's your barrier in getting to the primary care system? Is it transportation? Is it child care because you have to find a place for your kids to go? Do you have to miss work? And trying to address all the surrounding needs so that the person can be supported and ensure better adherence to treatment and improved health outcomes. So we're applying those same kinds of lessons in Indianapolis, where we've got huge disparities. These are neighborhoods where people have a shorter life expectancy, roughly 14 years shorter than the rest of the state. We've got a way higher burden of diabetes, 17% compared to 9% in the statewide. And then we've also got a lot of other determining factors that community health workers can really help to address in partnership. For example, access to good, healthy food. Mm-hmm. There aren't many grocery stores, or food prices could be expensive. So looking at different ways to provide access to healthy food. Sorry, go ahead.
Well, I wanted to ask, I know I'm reaching you in Mexico. I know that the pilot that you're rolling out in Indianapolis is based on positive results you've seen in places like Mexico and India. Can you just sort of talk me through what those projects look like in, say, India or Mexico?
Sure. So in India, we've got a complex health system where about 70% of people seek treatment in the private sector regardless of their income level. That private sector is quite fragmented. You could go to the mom and pop pharmacy shop, to a high scale private general doctor, to a wide range, right? They often see 2 to 3 providers looking for care or a better diagnosis before landing in one. This leads to difficulties in following people up for care and ensuring that they're staying on treatment. So in India, we implemented a community health worker model to accompany people both through the public health system, but more importantly, through the cadre of private providers.
And so just to be clear, by community health worker model, you mean that you're training individuals who are of the community, in the community, in sort of basically like sort of health social work?
Yeah, things I take it for granted that I don't usually explain it, but yes. So it is training, but training is a means to an end, right? So we're training people from those local communities to help with tackle specific issues. So in India, the 2 main issues are, or pain points are from initial screening to confirmatory diagnosis, so not going back to the facility to get that confirmation that they have diabetes. And the second main pain point is the treatment continuation after 3 months. So we're training people from the community to identify who needs to be screened and help follow up when they don't show up at a facility. We're giving them the tools and the ability to do some of that work out in the neighborhoods and at the facilities. And then that treatment continuation is training the community health workers to provide education and awareness on diet needs, on physical activity, or on services that could wrap around care for the individual. So it is a bit of a social worker, it is a bit of a health care provider in terms of information sharing, and sometimes they're neighbors and family members, so that they're part of the community and can just support people with the needs that they have.
And it's sort of that idea, that model that you're piloting in the United States.
Yeah, so we are working with people from these 3 key neighborhoods in Indianapolis. We'll be training them, and they'll be getting support from all of the different partners to reach back out into their community, find people who might not yet have diabetes. So here it's a little bit more focused on preventing the disease as well as the initial stages, to identify the most critical and modifiable health risks and have the community health workers tackle those in partnership with the broader community and partners.
Can you talk a little bit about the link between diabetes and poverty? These 3 communities that you're working in, as you said earlier, are poorer communities compared to the rest of the city and the rest of the state, and presumably that linkage between diabetes and poverty is probably as prevalent in places like India and Mexico where you are. So, what is that link?
It's a very interesting question. So I'm going to first talk about perception and then reality. And until recently, diabetes in many countries was considered as a you made it kind of disease. So if you got diabetes, it meant you had the ability to eat more and you had the financial power to buy more things that could give you diabetes. So that's all about perception. In countries, especially like India and to some extent South Africa, that's very much there. The problem is that we're seeing diabetes there's a higher burden of diabetes in low and lower middle income countries, as well as in lower income populations within the U.S., because the food choices they have are of lower quality sometimes, because there isn't as much ability or focus to exercise, because they're so focused on the basic needs of keeping a roof over their head and feeding their kiddos that they don't always have the luxury of going and getting tested, of getting screened, of addressing their risk factors. And because often the physical structure of these communities is worse off than others, then there's no easy way, there's no green space or easy way to exercise or walk to work. It might be too dangerous. So now we're seeing that poverty is very clearly linked with multiple non-communicable diseases such as diabetes and hypertension. And the consequences are enormous and just growing if we don't tackle them earlier. So this pilot work in Indianapolis is really key to contributing to figuring out what exactly works and then scaling it first across the county and then hopefully across the state with partnership with government.
Is it fair to say that diabetes rates are not as high in, say, Europe or Canada, where they have more functioning, more equitable health systems than we have here in the United States. That, the diabetes we see here is a function of broader inequality within our society and broader, larger barriers to access to the healthcare system that we have here, as opposed to other countries in Western Europe that have more equitable health systems.
I don't know enough to say if it can equate to equitable health systems. I know that there are a lot of factors contributing to diabetes, including genetics and propensity, including environmental factors, including socioeconomic factors. And yes, we do have lower rates in Western Europe. I'm sure it's all of those factors that contribute to that. The U.S. has very alarmingly high rates of diabetes in low-income populations, as well as in some particular geographic locations like the Rust Belt, the South, and that is also heavily driven by diet.
Can I ask? So, Lilly, your company, you're not a charity. You're a publicly traded healthcare company. Why is Lilly doing this? Like, what's the incentive here?
Lilly has a long history of giving back, so there is a philanthropic component to this. Yet we're learning from this. It will help our business, our knowledge on diabetes, and we're in the business of diabetes. That's one of our largest portfolios. So there's a few reasons. I mean, being from the Midwest, we have that giving back culture. Since the Eli Lilly family was in the business, but more recently, I mean, we think it's the right thing to do, and we are helping our customers, which are often governments and people affected by diabetes, tackle these solutions that medicines alone cannot solve. So we want to be the preferred partner to our customers, and as well as strengthening our communities so that they're healthier, more vibrant, giving back, and also that the medicines can work better. There's key health systems challenges in these around diabetes that just cannot be tackled alone with a pill or an injection. And we feel like it's our responsibility to help support that. Those learnings then also help us for future business and markets, for sure.
So this pilot is partnered with a university. Presumably, there'll be some sort of testing and some sort of scientific testing of the results and the outcome. Is that like a proper assumption that, in a few years' time, we'll get a sense of how successful or not this pilot study, this pilot program is?
Yeah, so Lilly's global health work operates under a framework we call Research Report Advocate. There's key research questions each pilot in every country is trying to answer. We report out on the data, the good, the bad, and the ugly, so that we learn from both our successes as well as our mistakes, and others can do the same. And then we advocate for what works to be replicated or scaled. We do this with our partners for sure. So in this particular program, there's key questions. We're hoping to see after these 5 years or in the middle, we'll be doing some assessments, an increased knowledge of diabetes, and we'll see an increased rate of testing. We'll see, hopefully, an increase in number of people diagnosed with diabetes, as well as effectively engaged in care. And then ultimately, we'll see improved diabetes control and decreased rates of life-altering and life-threatening complications. So right now, there's a baseline being done to see where we are when we start. As well, there's some key informative discussions and stakeholder consultations going on within the three communities so that the solutions are driven by community needs and community members. And then every year we'll have results to see how those interventions that are being tested have impact. If they work, we'll keep them going. If they don't work, we'll need to shift course. So that ultimately at the end, we'll have a key set of recommendations on what's tried and tested that can be changed to policy or replicated.
Taking a step back, can you sort of think of any other examples of healthcare interventions that were developed in poorer countries in the developing world being applied here in the United States?
Outside of this one?
Yeah, outside of this one. Is this like part of a broader trend?
I think it happens more often than not with the nonprofits that are doing work in the U.S. and abroad, especially those that are based in the U.S. They test multiple things in various countries where they're getting grants for, and then those learnings are clearly applied in their backyards. I have a few in mind, but I don't want to call out one in particular as I'm not totally up to date with them. Mm-hmm. But
the what Lilly is doing here is sort of not isolated. There are other examples out there of sort of the global being applied like to the local.
I would say there are other examples. Is it common and robust in terms of evaluation and impact? I'm not sure. I know our approach will definitely have that rigorous evaluation aspect to see of those global lessons that worked very well in that particular setting and geography, which of those can be applied locally, and how can we measure that impact?
Well, I'm looking forward to catching up in a few years and talking to you and seeing if diabetes rates in these three communities in Indianapolis have decreased thanks to this intervention.
Oh, I really hope so.
Thank you so much for your time, Amy.
Thank you, Mark. I appreciate it.
I'll stop recording now. Can I ask, I forgot to ask you at the outset, what's your official title that I can use when I introduce you?
It's a very long title. It's Global Health Thought Leadership and Policy Director.
Okay, well I can include that. That's a good one. Well, I appreciate that. Thank you so much for your time.
Thank you so much.
Okay, good luck. Bye.
Okay, take care. Bye.
All right, thank you all for listening. Thank you to Amy. And before I let you go, I want to let you know that I have still just a few stickers left that I'd love to send to you if you write a review of the podcast on iTunes. Just write a review, send me an email letting me know you wrote the review, and I will send you one of our fancy Global Dispatches podcast stickers. Who could resist? All right, see you later. Bye.